Thank you, Dr. Vaishnavi, Manoj Patel sir, and Dayani sir. Good evening, good afternoon, and good morning. This is the 1538th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. Suvarna Rajesh Kale. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors. We have 3 sessions every day. The first session of the day in Hindi is already over from 7:30 to 8:30, and from 8:30 to 9:30 we have the international session in English, and from 9:30 to 10:30 a local language session in Malayalam. All these sessions are going in a good way, and we are uploading the videos of the same on the very next day itself, so that those who miss the session can watch it again on the YouTube by searching our channel IFBH Homeopathy. And if you want to subscribe, you can subscribe it without paying a penny. That's the beauty of the International Forum for Promoting Homeopathy. The purpose is to promote, to take homeopathy to every home all around the world. That's the purpose, and we are doing such things for the last 1,537 days. And so hope all of you will be sharing the videos to all your groups around the world. And today, let me introduce the guest of the day. That is Dr. Suvarna Rajesh Kale. She has completed MD and working as an associate professor, Department of Gynecology and Obstetrics, Srimadi K.B. Abad, Homeopathic Medical College, Chandwad, Nausik. And is a very good personality, having 24 years of teaching experience as well as clinical experience. And she has held so many positions as custodian, moderator, examiner, centers in charge, academic coordinator, exam coordinator, resource person, MUHS of health science and technology, conducted 9 workshops of HSCT at different colleges in Maharashtra, and she has undertook a research project ongoing to explore the comparison between emotion and neck pain in the age group of 15 to 25, and observational pilot study completed, and prevalence of PCOD, irregular menses, with the efficacy of homeopathic medicine in 2017, and research. She had published some research articles also. The purpura fever with affection to urinary tract, vital informer, March 27, and abortion and its homeopathic management, vital information, in June 2018. So let's just proudly welcome the guest of the day, Dr. Rajesh Kale. Welcome, madam. Please yourself.
Okay. Now, first of all, I would like to thank the administrator for slide काय केलं समजते काय केलं यार. So here today we are going to discuss about PPH, that is postpartum hemorrhage. Postpartum hemorrhage is one of the important topic related with complication of third stage of labor. Now, complication of third stage of labor. In complication of third stage of labor, we know one of the most common complication is PPH. So before discussing for PPH, I would like to tell you, first of all, we should understand what is important regarding the third stage of labor. Now, third stage of labor is nothing but it is called as a placental stage, which starts after the expulsion of the fetus and ends after the expulsion of the placenta. Now, the duration required for the third stage is around 15 to 20 minutes. Now, what are the events which take place in the third stage of labor is, we know the placenta gets separates. Now, the separation of the placenta is by 2 methods. It may be central separation or marginal separation. Central separation is called as a Schultz method, and marginal suppression is called as a Matthew Duncan's method. Now, in the third stage of labor, we say it is the most crucial stage for the mother, because if it is not managed properly, it can lead into different complications. Now, what are the important complications which we see in our clinical practice is the most important complication is the PPH. Second, it could be retention of the placenta. The female may go into shock. It may be an hemorrhagic or non-hemorrhagic shock. Next complication, it may be the pulmonary embolism, either with the help of the amniotic fluid, or it may be by the air. And last, it is uterine inversion. So these are the complications which are seen after the third stage of labor. Now, what is PPH actually? PPH is nothing but we say it is an arbitrary and it is related to the amount of blood loss. If the amount of blood loss is more than 500 ml after the vaginal birth, we say it is quantitative definition of PPH. If the amount of blood loss is more than 1000 ml, we say it is during the cesarean section, then we may say that it is an PPH. But it is not wholly acceptable from the clinical point of view. So here, the proper definition of PPH is the amount of blood bleeding which occurs from or into the genital tract following the birth of the baby, or we say in the purpurium, which adversely affect the condition of the patient, which is being evidenced by the rise of the pulse or falling of the BP, then we say the female goes into the condition called as PPH. Now, PPH are of two types: primary PPH and secondary PPH. Primary PPH, we say if the bleeding is going to occur before the expulsion of the placenta. It is a theoretical definition, but true PPH is bleeding which occurs subsequently to the expulsion of the placenta. That is, which is seen in the majority of the cases, which is also called as a true PPH. Secondary PPH is also called as a delayed PPH, which occurs after 24 hours or after few weeks. Now, here we are talking about bleeding, the loss of blood. First, now we have to know how the blood can be stopped. All the females who undergo labor have some amount of the bleeding, but the bleeding is into some specific amount. If it is go more than that amount, then we say it is a profuse blood loss, or we say it is the female has gone into the case of PPH. So here there are certain phenomena which help in stopping the bleeding, which is occurring naturally. So here, what are the important phenomena which help or arresting the bleeding? Now we know during pregnancy, the female goes into the stage called as hypercoagulability. So hypercoagulability, that is increase in the platelet counts, which help in formation of the thrombus. So it is a spontaneous process which stops bleeding spontaneously or naturally following the labor, which doesn't leads into PPH. So this second phenomena is, we know the uterine muscle fiber has a specific property of retraction. Now, retraction is a word which says that the uterine muscle fibers goes into a stage of permanent shortening. Here we can say the muscle fiber in the relaxed phase is being quite big or elongated. Now, during the pregnancy, we know the uterus contracts and relaxes, but the retraction process occurs only during labor, it is a unique property in the uterine muscle fiber, which is called as permanent shortening of the muscle fiber. And due to this permanent shortening of the muscle fiber, the upper uterine segment, which is said to be an active segment, undergoes thickening and thickening, and the lower segment, which is called as a passive segment, is being elongated and elongated. So for that, we should know the physiology of the uterine muscle fibers. We know the uterine muscle fibers, we see in the upper segment only longitudinal muscle fibers are there, but in the intermediate layer we say the muscle fibers are arranged in a zigzag manner, or we say they are acting as a leading ligature. And in the lower segment, that is the inner layer of the muscle fiber, it is rich in the circular muscle fibers. So here, when the female goes in labor, during the process of retraction, this intermediate muscle fibers undergo retraction, which act as a leading ligature, and this helps in arresting the bleeding. So here, when the female goes for normal labor, the female doesn't go into PPH. All the female doesn't go into PPH. The female has some amount of the blood loss and the bleeding is being arrested, which occurs spontaneously. So this is the other phenomena due to which the female is being female is being prevented from going into PPH. This is the second phenomena, that is called as a leaving ligature phenomena. Third phenomena is after the expulsion of the fetus, the wall of the uterus, it collapse against each other, so it act as a tamponade. So this is the third phenomena which helps in arresting the bleeding. So these are some of the phenomena which help in arresting the bleeding. So many of the female doesn't go into PPH. Now, how to calculate the amount of the blood loss? The circulation of the maternal blood volume in a non-pregnant state, we say it is the total blood volume. It is being calculated by height of the uterus in inches multiplied by 50, and it is added with the weight in the pounds of the female multiplied by 20 divided by 2. So this is the pregnancy total blood volume, which is about 50% more than the non-pregnant female. But when the female goes into the PPH, that is acute return of the pregnancy of the total blood volume goes back to its normal. Now, here we are going to see what are the causes due to which the female goes into primary PPH. What are the causes of primary PPH? So, primary PPH, we see that it occurs immediately within 24 hours, which is called as a primary PPH. So, we say the causes are nothing, but there are 4 T's. So, 4 T's are nothing. The first important is the tone of the uterus. So, the most common cause of the PPH, that is primary PPH, is uterine atonicity. The tone of the muscle fiber is being lost. So we say it is called as uterine atonicity. Second cause is the tissues. The tissues are nothing but the product of conceptions which are inside the uterine cavity. So most important product of conception is the placenta, or we say the placental membranes. If they are retained inside, then it gives rise to PPH. Third cause is trauma, or we say injury. So injury may be in the form of episiotomy, it may be in the form of cesarean section, or it is in the unplanned vaginal or cervical tear, or any surgery which is causing trauma to the genital tract. That could be one of the cause of the PPH that includes under trauma. And last is the thrombin. Last T is the thrombin, in which the patient suffers from the bleeding disorders. For example, it could be congenital, it can be acquired. So it may be DIC, or there could be dilution of the coagulation factors, which give rise to a bleeding tendency in the female, and that give rise to PPH in the female. So these are the important 4 T's which give rise to primary PPH. Now, what is atonicity of an uterus, which is the commonest cause of the PPH? So here, as the placenta remains unseparated, the placenta fails to get separated, the bleeding is unlikely. Just now I have told you, in the third stage of labor, we know the placenta separates. placenta separates, then it descends, and last process is expulsion of the placenta. So if the placenta fails to separate and the wall of the line of cleavage of the placenta is, we say it separates from the deciduous spongiosum, because it is one type, it is nothing but the endometrial layer of the uterus through which the placenta is getting separated. So when the placenta is unseparated, the bleeding is likely to occur because it give rise to untonicity of a uterus. The tone of the uterus is lost. Now, with the separation of the placenta, what happens is the uterine sinuses are opened up. They are being exposed. So, which are torn because the placental separation is because of there is disruption between the surface area of the uterine wall and the placenta. So, because of the retraction of the muscle fibers, what happens? The sinuses of the uterus are torn, which fails to get compressed because of a tonicity of the uterus, and this leads to an profuse bleeding, and this give rise to PPH in the female. So this is one of the cause of atonicity of an uterus. So atonicity of the uterus in 80% of the female could be because of high parity. That means, in other words, we can say if a female is grand multipara, that means the female has delivered more than 4 or 5 times. So if the female has gone for a delivery or pregnancy for more than 4 or 5 times, I am not talking about only conceiving the pregnancy. If the female has reached the term, full term, that means the female has gone beyond 37 weeks of pregnancy or 38 weeks of pregnancy, and the female when goes into the labor, then we say the female is highly parous. That means the female is multigravida or multiparous female. So if the female is highly parous or multigravida female, she is likely to go for untonicity of the muscle fiber, due to which the female leads into PPH. Next cause is over distension of the uterus. When the height of the uterus is over distended, for example, we know there are specific height of the uterus corresponding to the week of gestation. If the uterus is over distended, for example, we can see here the over distended uterus occurs when the female has multiple pregnancy. That means when she is conceiving more than one fetus, it may be two, it may be three, or it may be four, which give rise to over distension of the uterus. Next, if the female is having polyhydramnios. Polyhydramnios is a condition when the amniotic fluid is excessive. That means it is more than normal. So polyhydramnios, multiple pregnancy, are or the female is having a macrosomic baby. These are the examples of over distended uterus. If the uterus is over distended, naturally the tone of the muscle will be lost. Again, it gave rise to atonicity of the uterus, which gave rise to PPH in the female. Next cause is general anesthesia. Suppose if the female has been given general anesthesia during the process of labor. So general anesthesia hampers the process of uterine retraction, and due to which the female goes into the atonicity of the uterus, which is again one of the commonest cause of PPH. Next, if the myometrium is being poorly perfused by the blood, if it is poorly perfused by the by the blood, then again the female goes into atonicity of an uterus, and which give rise to PPH. Next cause is prolonged labor. Prolonged labor is when the labor duration is more than 18 hours. Now again, it depends on whether the female is a primi or the female is multipara. Now we know in primi female, she takes around 16 to 18 hours to complete the labor. I'm talking about first, second, and third stage, including all the three stages. If all the stages of the labor are not completed within 18 hours, then we say the labor will be said to be a prolonged labor. So if the labor is prolonged, we say the uterine muscle fibers are exhausted. So if the muscle fiber get exhausted, they fail to act normally. And one of the commonest function of the uterine muscle fiber during the labor is retraction. So if retraction fails, it gives rise to atonicity. So these are some of the important factors due to which the female goes into PPH. Next is following augmentation of the labor. Now, for example, if the female has undergone induction of labor, for example, if the female is overdated, or the female has an cervical dystocia where the female labor pains are efficient but the cervix fails to dilate. So here we have to augment the labor. Augmentation of labor is, that means the labor process has to be become more active. We have to increase the contractile activity of the myometrium. In these cases, we give oxytocin to the female. So here, if the female is suffering from uterine inertia, if the uterus is weak, it is inefficient, it is not efficiently working, so we augment the labor with the help of an oxytocin. So if we give oxytocin in an injudicious manner, so here again the myometrium fails to retract in that cases. So how much it should be given, again it should be decided by an expert physician, then only it will be acting in a positive manner. If it is being judiciously administered, then the uterine muscle fibers act in an abnormal way, due to which the retraction of the muscle fiber fails and the female goes into PPH. Next cause is uterine atonicity in the previous labor. That means the female uterine muscle fibers are not acting normally from the past pregnancy itself. So in that cases, the female is likely to go into PPH in the present or in the future pregnancy also. Next is the chorioamnionitis. Again, it is an infection of the amnion, that is the amniotic membrane. We know amniotic membrane is nothing but the one type of an fetal membrane. There are two types of fetal membrane, that is chorion and amnion. So if there is infection of an amnion, again it gives rise to an PPH because there is an infection. So indirectly there will be infection to the myometrium also, and myometrium fails to retract, it gives rise to PPH. Next cause is malformation of an uterus. It is also called as anomalies of the uterus. Now these are the different types of anomalies which we can see in the uterus. So if the uterus itself it is malformed, it is abnormal, so we know the myometrium is not going to function normally. So here, if the myometrium fails to contract, fails to retract, it is likely that the female goes into PPH. So malformed uterus may be bicornate uterus, unicornate uterus, it may be septate uterus, it may be arcuate uterus. So these are the examples of a malformed uterus. So if a female is having a malformed uterus, there are chances of PPH in the female. Next cause is uterine fibroid. Uterine fibroid is, we know it is also called as myoma. So if there are fibroids in the uterus, so the fibroid is nothing but it is a type of an growth in the myometrium. So if there are multiple fibroids, the fibroids are of different types. It may be intramural fibroid, it may be subserous fibroid, it may be submucosal fibroid. So if there are fibroids in the uterus, again the function of the myometrium doesn't occur to its normal function of the myometrium is being hampered, it doesn't act properly. Again the female is likely to go into PPH. Next important cause is very rapid labor. Very rapid labor is also called as precipitated labor. If the labor occurs in a very short period of time, for example, in a primary female, if the labor occurs within 6 hours, normally she takes around 12 to 16 hours. But if the primary female is undergoing a labor within 6 hours, we say this labor is called as an rapid labor, or we say it is an precipitated labor. So if there is a precipitated labor or an rapid labor, again the myometrium fails to act normally. The normal function of the myometrium fails to occur, and the retraction property again fails, and it gives rise to an PPH. Next cause of PPH is the female goes, there is mismanagement. If there is mismanagement of third stage of labor, for example, if you go for an early separation of an placenta, without seeing the signs of placental separation. We go for manual removal of the placenta without seeing the sign of the cleavage. So if there is mismanagement of the third stage of labor, that means we are not allowing the uterus to function normally, spontaneously. Again, the myometrium is going to act in an abnormal manner and the female goes into PPH. So these are the common causes of PPH. So here we say rapid delivery of the baby, preventing the myometrium to adapt its normal activity or normal content. If we are going for a premature attempt to deliver the placenta before the separation or before seeing the cleavage function. Next, we are going for the needling or fiddling of an uterus. That means we are pulling the umbilical cord before the placenta is separating. That means it leads to cupping of an uterus or inversion of the uterus. It is again one of the example of mismanagement of third stage of labor. Third is pulling of the cord. All this provides irregular uterine contractions. So there may be partial separation of the placenta, which give rise to profuse hemorrhage. And if there is a profuse hemorrhage, this is nothing but it is called as an postpartum hemorrhage. Next cause of PPH is constriction ring. Constriction ring is one type of abnormal uterine action which occurs in the female. It may in the first stage, in the second stage, or in the third stage. Now, as we are talking about PPH, constriction ring, if it is formed during the third stage of labor, it gives rise to PPH. Now, here this diagram shows there is a ring formation between the upper end of the uterus and between the trunk of the uterus. So this is occurring during the second stage of labor. Similarly, if the constriction ring is going to occur during the third stage of labor, when the placenta is being separated, but it fails to descend down. So if it fails to descend down and separation has been occurred, that means it is going to fail to expel the placenta. So indirectly, the female goes into the PPH condition or profuse bleeding. So if there is a constriction ring, that means again there is a spasm in the muscle fiber and the muscle fiber fails to retract, which give rise to PPH. Next cause may be incomplete separation of the placenta. Now we know the placenta is discoid in shape. There are many lobes, around 15 to 20 lobes in the placenta. Suppose placenta is separating partially or only one or two or lobes of the placenta are getting separated, but it is not separating in the whole or totally, then it give rise to again PPH. So if there is incomplete separation of the placenta, it is one of the cause of an PPH. Next cause is retained placenta. The placenta fails to get separate, or if it is separated, it fails to get expelled out or descend, then again the process is incomplete. So if the process is incomplete, the myometrium again shows an abnormality in its function. So if the abnormality in the functions is there, again it gives rise to an PPH. Next cause is abnormal adherent placenta. Abnormal adherent placenta means normally the placenta should get separated from the line of the cleavage. So I just now told you the line of the cleavage is deciduous spongiosum. Suppose during the process of implantation, if the chorionic villi are penetrating the line of the cleavage, it goes beyond the myometrium. So which may be occurring because of the anchoring villi, because villi are nothing but they are the part of the chorion which helps in implantation, which helps in nidation of the blastocyst. So if this anchoring villi goes beyond the myometrium, goes beyond the deciduous spongiosum, if they are invading the decidua basalis, then we say it give rise to an adherent placenta. Adherent placenta, the word itself tell you it is adherent. That means it has an adhesive property. So if it is adherent, naturally the placenta fails to get separated, and if it fails to get separated, the female goes into the profuse bleeding, which is called as postpartum hemorrhage. Okay. Next cause is the female goes if there is any abnormality in the placenta itself. Just now I told you the placenta has 15 to 20 lobes, but the lobe the placenta may have one of the common lobe, that is the normal lobe, or the female, the placenta may have an accessory lobe. So if the placenta is having an accessory lobe, that placenta is called as succenturate placenta. So this accessory lobe may be implanted at any other wall of the uterus apart from the normal wall of the uterus. Again, in that cases, that accessory lobe fails to get separate. So again, if it fails to get separate and the main lobe of the placenta is getting separated, then it may give rise to again PPH, that is profuse bleeding. Am I audible, sir? Hello?
Yes, yes, yes.
Hello?
Please,
Am I audible,
yes,
sir?
yes, please forward.
Everything fine,
Yes.
everything
Okay,
fine.
sir. Okay. Yes. Next cause of the PPH is placenta previa. Placenta previa is a condition when the placenta is implanted in the lower uterine segment. Now, during pregnancy, we know the uterus is having upper segment and lower segment. Normally, the placenta should get separated, should get implanted into the upper segment. Okay, it is always implanted in the upper segment of the uterus at the anterior or posterior wall. But if the placenta is implanted in the lower segment indirectly is near the cervix. Now, if it is implanted in the lower segment, we know the lower segment is derived from the isthmus part of the uterus. And isthmus part of the uterus doesn't have endometrium. And if it doesn't have endometrium, that means it doesn't have decidua. So if the decidual layer is absent in the lower segment, and if the placenta is implanted in the lower segment, then indirectly the separation of the placenta will get failed. The placental separation process get fails, and that give rise to an severe bleeding in the female, which give rise to PPH, that is postpartum hemorrhage. Next common cause of PPH, that is postpartum hemorrhage, is placental abruption. Placental abruption is also called as abruptio placenta, or it is also called as premature separation of placenta. Now, normally we know the placenta gets separated during the third stage of labor, that is only after expulsion of the fetus. If the placenta is separating after 28 weeks of pregnancy, that is during the third trimester, or if the placenta is separating during the first or second stage of labor, which is called as premature separation of placenta. So if the placenta is separating prematurely, that is during the last trimester of pregnancy, or it may be during the first stage or second stage of labor, there will be naturally bleeding in the uterus. Now, this bleeding may be concealed or it may be revealed. Revealed means it can be seen outside the vagina, and concealed it may be behind the placenta. That is why it is concealed type of bleeding. But if there is an abruptio placenta and there is a bleeding, what happens? The coagulation factors are going to get declined because of the bleeding, again depending on the amount of the bleeding. As the coagulation factors are getting deprived, the female following the labor fails to go for the process of coagulation. So if the clots are not formed, coagulations will not going to occur, then again the female will give rise to the condition called as profuse blood loss following the labor or after the expulsion of the placenta, and that condition is nothing but called as PPH. So placental abruption is also one of the important cause of PPH. Next is full bladder. If the bladder is full, next again it acts as an obstruction, then it gave rise to an PPH. So this is an example of an succenturate placenta, and these are the examples of the placenta previa. The placenta is attached in the lower segment, again depending on how far it is from the cervix or from the os. That is nothing but the condition called as placenta previa. So these were the causes of, just up till now we have discussed about the causes of PPH because of atonicity of an uterus. So there are many causes due to which the tone of the uterus is being lost. The myometrium fails to retract. So we say most of the causes of PPH is atonicity of the uterus. So around we have discussed about 10 to 12 causes of atonicity of the uterus, which is considered as 80% of the causes of PPH. Next cause of PPH is traumatic, or we say trauma. So traumatic causes, I told you, it may be trauma to the cervix, to the vagina, or during the giving an episiotomy incision to the female, or during the cesarean section. So if it is not being given by a trained or by a skilled person, it may give rise to a profuse bleeding, which may be 20% of the cause of an PPH. Second, there could be combination of the atonicity and traumatic causes, which give rise to PPH. And last cause is the coagulation disorders. Just now I told you it could be acquired or it could be traumatic. It may be congenital or it may be acquired, which give rise to PPH in the female. Just now I told you the traumatic causes. The trauma is usually following the operative delivery. It may be spontaneous delivery, blood loss from the episiotomy wound. Next, there could be severe blood loss from the cesarean section, which may be more than 800 to 1000 ml. The trauma may involve the injury to the cervix, vagina, perineum, or it may be paraurethral region, or it sometimes if there is an obstructed labor. If the labor is obstructed, very rarely obstructed labor is when it occurs, then it will give rise to rupture of the uterus. Now, it is a very severe condition. We know the rupture of the uterus may occur during pregnancy or during labor. But if the labor is obstructed, usually the uterus ruptures during the from the lower segment of the uterus, because lower segment thins out during the labor process. Just now I told you that the upper segment, because of retraction, become thick and thick, and the lower segment becomes thin and thin. As there is pulling of the lower uterine segment, the upper segment becoming shorter and shorter. And as the obstruction is not being relieved, the lower segment becomes thin, 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 and finally it gets ruptured. So again, it is a type of an trauma due to which the female goes into profuse internal bleeding. She goes into shock, and that give rise to an PPH. So the bleeding usually may be revealed, which is very rare, or it may be concealed, which may go into the vulva or vaginal, or it may go into the ligaments. So it is called as an hematoma of the ligament. So these are the different types of traumatic injuries which give rise to profuse bleeding in the female. Other risk factor which give rise to postpartum hemorrhage are antepartum hemorrhage. Now, what is antepartum hemorrhage? Antepartum hemorrhage is nothing when the female complains of pervaginal bleeding after 28 weeks of pregnancy, but before the third stage of labor. Okay, antepartum hemorrhage, that means during pregnancy. So if the female is having bleeding in the third trimester of pregnancy, we know the third trimester of pregnancy begins after the 28 weeks of pregnancy. So if the female is having bleeding after 28 weeks of pregnancy, but before the labor, we say it is antepartum hemorrhage. The commonest cause of antepartum hemorrhage is, just now I told you one example, that is abruptio placenta, when the placenta is separating prematurely. And second commonest cause of antepartum hemorrhage may be placenta previa. This also we have discussed. Placenta previa is nothing but it is a condition when the placenta is implanted in the lower uterine segment, that is near the cervix, or we can say near the os. So these are the risk factors. So female who is having an history of antepartum hemorrhage, that is she is having a complaint of bleeding per vagina after 28 weeks of pregnancy before the third stage, this female is said that she is prone to go into PPH after the labor. So we have to give an special attention to the female who are having the history of APH. Second, the females who are having the history of PPH in the previous labor or previous pregnancy, or the females who are having the history of retained placenta in the previous labor or following the labor, are risk to go for the PPH in the future. Next, the females who are suffering from anemia, or we say the females who are malnutrited or anemic females. These females are again prone to have PPH. The females who are suffering from ketoacidosis, those females are also prone to have PPH. The females who are suffering from HIV, the females who are suffering from AIDS, these are the females who are prone to have PPH. Next important is, after the primary PPH, we can go towards the secondary PPH. I told you secondary PPH is nothing but it is called as a delayed PPH, which occurs after a week. Okay, so it is not going to be seen, it is not going to be observed in initial phase. It is not going to seen, or it is not going to see, we can't see this immediately following the labor, but we can see it may be after a week. That is a secondary PPH. So here, what are the causes of secondary PPH? Secondary PPH may be because of the retained bits of the cotyledons or the membranes. Now, what is cotyledons? Cotyledons are nothing but the lobes. I told you these are the lobes of the placenta. So if the lobes of the placenta fails to get expelled, for example, if the placenta is not getting expelled or not getting separated completely, it may be a partial separation of the placenta. So if there is a partial separation of the placenta, we say there could be retained bits, or any one of the lobe may be retained inside, may be attached still to the uterine wall. So we say it is a retained bits of the placenta or the membrane. Membrane is nothing but we are talking about an amniotic membrane, which is covering the fetal surface of the placenta. So if any part of the membrane or any part of the cotyledon of the placenta is retained inside the uterine wall following the third stage of labor, will give rise to secondary PPH, may occur after 3-4 days or after a week. Second cause of secondary PPH may be infection. If the female suffer from infection following the labor, we say she goes into pyrexia, she may go into purpureal fever or pyrexia. So it may be because of the any slog which is there into the cervical vagina, or if the female is having any laceration or any injury, and if she is not going to maintain her hygiene, if hygienic condition of the female is not good, the hygiene is not being maintained, so the female is likely to go into infection. So this infected material which is inside the placenta, if it is getting slogged off, then it may give rise to a secondary PPH in the female. Next, if the female is having endometritis, endometritis is nothing but an inflammation of the endometrium, that is the innermost layer of an uterus. So if there is endometritis, sub-involution of the placental side. Placental site is nothing but the site where the placenta is attached, or we say where the placenta is being implanted. Normally, just now I have told you that the placenta is implanted always near the fundus, near the dome shape of an uterus at the anterior or posterior wall. Now, this side is the side where from where the placenta is getting separated, and this side is the side which takes time to heal. Suppose if during this period, if the hygiene of the female is not maintained, this side has a raw material for the bacteria to harvest, to have a good food. So this side is likely to get infected. And if it is infected, it will give rise to delayed healing. And if there is a delayed healing of this part of the uterus, then the uterus fails to involute. What is involution? Involution of the uterus is nothing but reverting back of an uterus to its pre-pregnant state. The uterus which was distended during pregnancy, which had reached up till the level of the zipisternum during the pregnancy, following the labor, this uterus will revert back to the pre-pregnant state, which takes around 6 weeks. Now, if this process of involution doesn't occur, if it fails because of infection, then that process is called as sub-involution of uterus. So
Madam,
if there is a sub-involution of,
hello,
so if
hello,
there is a female is having a secondary PPH, it will give rise to sub-involution of a
hello,
uterus.
madam,
So
hello,
secondary hemorrhage. Hello, sir.
hello, madam. How many slides remaining?
Am
Because
I audible, sir?
yes, just 5 minutes remaining. How many slides remaining? Can
Yes,
you
only
hear?
few slides are there, sir.
Okay.
Should I continue?
Yes, we can
Okay.
for 3 minutes. Okay.
Yes, yes, sir. Yes, sir. Okay, yes.
Madam,
Secondary hemorrhage may be following the cesarean section, which may be because of the suppression of the slog, which may be because of the profuse bleeding, or it may be from the granulation tissues. Now, other causes of secondary PPH may be if there is withdrawal, there may be a withdrawal bleeding following the withdrawal of the estrogen therapy in the female in whom we are going for suppression of lactation. So this is seen in the female who gave rise to an stillbirth baby. So if we are giving estrogen to the female for suppressing the lactation, this give rise to a withdrawal bleeding. So withdrawal bleeding occurs following a week, and which give rise to, and which is nothing but secondary PPH. Next could be because of if the female is having chorionic epithelioma, which occurs beyond the 4th week. Next, the female may have carcinoma of the cervix or placental polyp, which may give rise to PPH in the female. So if a female is having PPH, what is the clinical features? There will be a visible bleeding in the female. The female may go into an collapse state, or so most important signs which we see is there will be rise in the pulse, pallorness will be there, falling in the BP. Again, depending on the amount of the blood loss, the female may have altered level of consciousness. She may be restless, she may be drowsy. The uterus may be flabby, enlarged, boggy because the uterus has failed to retract. So diagnosis of the PPH will depend on how much amount of the blood is being lost in how much time. So if there may be slow trickling of the blood, rarely it may be of concealed or it may be an vulvovaginal bleeding. The effect of the blood loss will depend on how much is the hemoglobin level of the female during pregnancy, then degree of pregnancy induced hypervolemia, how much amount of the blood volume has been increased, and speed by which the blood is getting lost. So here the condition will give rise to increase in the pulse, decrease in the blood pressure, and we have to see if the blood volume is lost for 20 to 25%. We say it is a second degree of hemorrhage, and the blood loss may be rapid, it may be brisk, and the female may die within a very short period of time. So here the status of the uterus can be seen by examining the uterus. We will see that the uterus will be flabby. It will not be contracted. So it is one of the signs that the uterus is atonic. So both atonicity and traumatic causes will give rise to a massive bleeding in the female. And we can see the general condition of the female may be dechlarating. So how you can prevent the PPH here? PPH can be prevented by taking care of the female during the pregnancy itself, which is called as antenatal prevention, and it can be prevented by taking care of the female during the labor. So antenatal prevention by keeping the hemoglobin level to a normal, improve the hemoglobin level of the labor. So hemoglobin should be more than around 10 gram %. High risk cases should be screened. Blood grouping of the female should be done. The female thromboembolism process prophylaxis should be seen. The women who are having the risk of thromboembolism or taking aspirin should be screened properly. The amount of the aspirin what is being given to the female should be seen, how much amount, on what are the effect of this aspirin on the female. Next, intranatal, that is during the labor, what care should be given? The female who is coming for the labor, who are taking therapeutic heparin to the female, so heparin activity should be fall to the safe level, so that the female should not go into the bleeding phase following the labor. That has to be taken. Next, you should prevent precipitated labor. That means the delivery of the baby should be spontaneous, slow delivery should occur. Next, anesthesia, deep anesthesia should not be given. Just now we have seen one of the commonest cause of PPH is giving deep anesthesia. Then there should be no mismanagement of the third stage of the labor. Following the labor, you should give uterotonic to the female so that the uterus will go into the normal function. We should avoid pulling of the cord before seeing the line of the cleavage, which will help in filling or knitting of an uterus. Examine the placenta and the membrane when it is being extracted, when it is being expelled out. Second important thing, you should continue the oxytocin dose to the female at least for 1 hour following the labor, so that the uterus will go into the normal contractile activity, which will help in retraction and help in preventing the PPH in the female or profuse bleeding. Then check the genital tract for any trauma. Observe the female for about 2 hours following the labor. So these are the preventive measures which should be seen. Next is you have to go for
Okay.
investigations. You have to go for total blood count.
Okay, madam.
Coagulation
Hello,
study should be
madam.
done.
Hello,
So
madam.
here
Time.
continue blood pressure monitoring should be done. Pulse monitoring should be done. You have to use the oximeter to see all these things. Next,
Oh,
immediate care of the female following the labor should, you have to communicate, resuscitate the female, monitor the female, and most important thing is you have to stop the bleeding immediately. So
okay,
the
madam.
principles of management of the third stage of labor is you have to empty the uterus, its content, and make the uterus contracted. Whatever has been lost has to be replaced so that the female should not go into the shock. And last is you have to go for effective hemostasis if the bleeding is from because of the trauma. So you have
Okay.
to go for traumatic management.
Okay,
Next
madam.
step of the management is you
Hello.
have to see the placental side for the
Hello.
bleeding,
Hello,
traumatic
madam.
side for the bleeding.
Hello,
So
madam.
for controlling the placental side of the bleeding, we have to go for a slight massage. Keep the hand on the fundus and massage the uterus, which will help in contracting the uterus. Or we can give an methargine to the female in 0.2 mg, which can be given intravenously along with the dextrose. And if it is not controlled, then we can go for a blood transfusion, catheterize the uterus. If it is full, sedation can be given if the uterus is undergoing an abnormal action. Next, these are the process of manual removal
Hello,
of the placenta. We can go
hello,
for a
madam.
manual
Hello,
removal
madam.
of the placenta.
Madam.
Hello?
Hello, madam. Time is already over. We can have a second part of the same with the
Okay, sir.
because we have another session coming on.
Okay, okay. I will stop, sir, then. Okay.
Okay, okay. We can conclude here and then we can have a second
Yes,
part.
sir. Okay. Thank you. Thank you very much. Okay.
Please,
Yes, sir.
please
Okay.
continue. Please
Yes.
wait. We will have a. Now I invite Dr. As there is no time for discussion, I
Okay.
invite Dr. Sri Lakshmi to say a vote of thanks. Dr. Sri Lakshmi from Qatar.
Good evening to all of you. Can you hear me, sir?
Yes, yes.
Yes.
I sincerely thank you, Dr. Suvarna, for your incredible session on the complications of third stage of labor, especially on PPH, on behalf of IFPH and on behalf of myself. And I am thanking all the participants, those who are present, for your patient listening to the section. Thank you. Thank you all.
Thank you, Dr. Sri Lakshmi. Thank you, Dr. Suvarna Rajesh Kale, and those who attend the session. Tomorrow we will have a session from Dr. Ellen Therian from Tamil Nadu. Doctor will be talking about efficacy of homeopathy in the management of psoriasis. With that, we come to the end of the day 1538. It's over to Dr. P. Shaila to moderate the Malayalam session. Thank you all. Good night. See you tomorrow at the same time.